Okay, well, we'll make a start. Good afternoon, everyone, and welcome to Paediatric Teaching. Today, I thought we'd talk about acute diarrhea. It's a very common problem, and we haven't spoken about it before, but I thought we'd talk about it in the context of the information we now know about the different causes of acute diarrhea and about its pathophysiology. So it'll help those who are doing their part one in terms of an understanding of pathophysiology. And we'll also talk about the assessment and treatment of acute diarrhea. Diarrhea makes up about 8% of all hospital admissions in the paediatric hospital reporting program every year for the last 15 years. It's been around about 8% of all admissions, and about 5% of all deaths are associated with diarrhea. Typically, the case fatality rate in hospitals for diarrhea is about 4%. So not nearly as high a case fatality rate as some other diseases, but still we need to get the management of diarrhea right, otherwise children can die. And the major cause of death in diarrhea is dehydration, if we don't get dehydration right, and sepsis, a more generalized systemic infection related to the diarrhea. And it depends on the etiology, it depends on the causes. Now, of course, most diarrhea is acute watery diarrhea or acute viral gastroenteritis, and most of that is due to rotavirus. But if you take an entire population of children hospitalized with diarrhea, then we know that mortality is substantially associated with underlying malnutrition. So the children who are malnourished are more likely to die. And if the cause is something other than rotavirus, if the cause is Shigella or E. coli or Campylobacter. We'll talk more about those bacterial causes of diarrhea as we go, but just to know that the risk of death is most associated with underlying malnutrition, especially children with severe malnutrition and other comorbidities, and if they have a bacterial infection rather than having a rotavirus infection. So well-nourished children who get rotavirus shouldn't die unless we don't get the rehydration right. There are definitions of what diarrhea is because there are WHO has a definition. It's just excessive loss of fluid and electrolytes in stool of an amount sufficient to render the patient ill. That is, if a child is sick from loss of fluid and electrolytes in their stool in the whatever frequency of diarrhea and whatever volume, then that is sufficient to call it diarrhea. I wanted to mention the information we now have about the cause of diarrhea, and that's in recent years there's been a worldwide study that's called the GEMS study, and it looked into the causes of diarrhea in over 9,000 children who had moderate or severe diarrhea, moderate to severe dehydration with diarrhea. And it's very interesting because it's in almost all countries, the top 4 causes of diarrhea were the same. And that was rotavirus causes somewhere between 40 and 50% of all diarrhea in all countries. Now, it's even more in some epidemics or outbreaks of rotavirus, and it's a bit less some years when there's less rotavirus around. But overall, about 40 to 50% of all diarrhea in children is due to rotavirus. But the other pathogens, the other top 4 are very important. So E. coli is very important. Enterotoxigenic E. coli is an important cause of diarrhea, and like the next 2 are strongly associated with mortality. So Campylobacter jejuni and Shigella flexneri. Now we get used to Shigella diarrhea as most commonly causing dysentery. Campylobacter can just cause watery diarrhea, profuse watery diarrhea, and enterotoxigenic E. coli can either cause dysentery or just acute watery diarrhea. So it's sometimes a challenge to separate out what's just acute viral diarrhea, viral gastroenteritis, from what might be a cause of bacterial diarrhea. And that has major implications because we don't want to be giving antibiotics to all children with diarrhea. In fact, children with rotavirus diarrhea will do better if they don't get antibiotics. But we don't also want to miss children who've got the other three main causes of diarrhea. We'll look at that in a bit more detail. This is a photomicrograph of rotavirus, and you can see why they call it rotavirus. It's these are the viral particles, and this is enterotoxigenic E. coli, again under a photomicrograph, which magnifies it. So it's a gram-negative bacillus. These are gram stains. If you do gram stains on of the four main bacterial pathogens of diarrhea, and that three of them are gram-negative. So E. coli, Campylobacter, and Shigella. They all look a bit the same, slightly different density of staining, but E. coli is more a bacillus. Campylobacter is a gram-negative bacillus, but it also has these spindle formations on the end of it. So that's how you recognize Campylobacter under the microscope in a stool wet preparation, is that it's not just a gram-negative bacillus, but it also has sort of spiral formations on the end of on the front and back end of the bacteria. And Shigella flexneri can look very similar to E. coli under the microscope. The other pathogen I've included here is Clostridium perfringens, which is a cause. It's a gram-positive bacillus, and it's a cause of diarrhea and bloody diarrhea in Enteritis necroticans or in pig bell. But the major causes of acute watery diarrhea or acute dysentery are these three bacteria plus rotavirus. Remember, rotavirus causes about half of all cases of diarrhea. I wanted to talk about the mechanisms of diarrhea, because each of the pathogens, whether it's rotavirus or the bacteria, have slightly different mechanisms of diarrhea or slightly different ways in which they cause water and electrolyte loss. But normally, the active transport of water, the active uptake of water, the absorption of water in the intestinal mucosa is determined by active transport of glucose and sodium and chloride. That's active transport in the enterocytes, the mucosal lining of the gastrointestinal tract, active uptake of glucose, and with every molecule of glucose comes a molecule of sodium and comes water molecules. So that requires that the intestinal mucosa has a normal enterocyte pattern, and that's quite disrupted, especially by rotavirus diarrhea, and the internal mechanisms for absorption of water and sodium and chloride are disrupted in bacterial diarrhea. Most of the diarrhea, the defect in water and solute absorption, occurs in the small bowel, because the large bowel, the colon, has a very limited capacity to accommodate an increased water load from the upper gut. So once the water hasn't been absorbed in the small bowel, then it'll just flow rapidly through the colon, because the colon doesn't have the same microvillous large surface area that the small bowel does. The small bowel has a very, very large surface area with lots of enterocytes that have mechanisms for the absorption of glucose, sodium, and chloride, and water with it. So most of the mechanisms for diarrhea occur because of disease that's occurring in the small bowel. There's some other mechanisms that sometimes cause diarrhea in some circumstances. Hyperperistalsis, we'll talk a bit about that, where you've got increased peristalsis of the gut. So even when the absorptive capacity of the small bowel is not so affected, not that much water can be absorbed because it's not in the small bowel for long enough. And then sometimes osmotic diarrhea that occurs if a child who's got, say, rotavirus diarrhea has a hyperosmolar feed. So, for example, if a child with rotavirus diarrhea is rehydrated with lemonade, then that's got a lot of sugar in it, say Sprite, then it has a lot of sugar in it, and that the high sugar content will draw more water from the small bowel into the lumen of the small bowels, from the small bowel wall into the lumen, and make the diarrhea much worse. So anything that there's some other sports drinks like Lucozade they're hyperosmolar. They have a high osmolarity, and that draws water from the small bowel wall into the lumen, making the diarrhea much worse. That's why oral rehydration solution has a much lower glucose content than say lemonade or Sprite or Coke or any of those other commercial products. So in rotavirus diarrhea, I mentioned that the main issue is the loss of the enterocytes, being the enteric mucosal cells of the small bowel. And they normally have what's called a microvillus structure. And normally the microvilli look like this, but you can see this is a pig that was infected with rotavirus diarrhea, and rotavirus can occur in animals as well. This is the intestine, where you can see the destruction of the villi, and they're not like the normal larger villi. They're blunted and shorter, and therefore the surface area for absorption is much less. And if that happens, then this glucose sodium chloride water transporter is impaired. Usually with rotavirus diarrhea, after exposure to the virus, within 48 to 2 to 3 days, a child will become unwell. Usually starts with vomiting and then followed by diarrhea. And often the diarrhea can be quite profuse. The child may have fever or not. And in about 20 to 40% of cases, children with rotavirus diarrhea will have some respiratory symptoms. They may have cough or they may have tachypnea because of acidosis, but respiratory symptoms are not uncommon. And sometimes those children are misdiagnosed as having pneumonia. So important to realise. The bacterial causes of diarrhea cause water and chloride and sodium loss by another mechanism. And it's important to understand this. For those who've just done the part 1 or are doing the part 1, you'll remember we've talked about intracellular mechanisms or intracellular signals that can occur, and one of them being the acceleration of production of adenylate cyclase or guanylate cyclase. They are intracellular signaling transmitters, and in E. coli, enterotoxigenic E. coli, it's not the bacteria that gets into cells as rotavirus gets into cells. It's the bacteria produces a toxin that is absorbed within a cell, and it activates this intercellular regulator called adenylate cyclase, and that produces more ATP, the energy production chemical of the cell, and by various mechanisms increases cyclic AMP formation, and that leads to a loss of water and electrolytes and chloride. So just to know that the mechanisms of enterotoxigenic E. coli involve the activation of adenylate cyclase within cells that, again, may come up in the part 1 as a cell mediator, signal transporter within cells. But the effect is the same. There's not a destruction of the microvilli, but there's an outpouring of water and sodium and chloride, and a block in the uptake in the absorption of those water and sodium and chloride. There's 2 sorts of toxin with enterotoxigenic E. coli. There's a heat labile one, which means it's responsive to heat or susceptible to heat, and a heat stable toxin. They both can cause diarrhea. Probably the heat stable toxin is a bit common than the heat labile toxin. Some other causes of diarrhea include Staph aureus, which a form of Staph aureus can produce an enterotoxin that leads to profuse vomiting, usually within about 4 hours of the staph being ingested. Usually it's in, for example, poorly cooked rice or rice that's been in not been refrigerated appropriately, and the staph that gets in the rice produces toxin and can lead to an acute onset of vomiting and often massive watery diarrhea from hyperperistalsis that occurs within about 4 hours, and it's usually gone. Staph food poisoning is usually gone within 24 hours, but it can cause major vomiting and diarrhea in that time. And I've talked a bit about Clostridium perfringens as a cause of pig bell, and that again has a different mechanism. It causes ischemia also by the production of an enterotoxin. So bacteria more function causing diarrhea by the production of toxins, whereas rotavirus causes diarrhea by the destruction of the microbial within the gastrointestinal tract. Now, we've talked about this before, but the stages of management of any sick child, regardless of what their problem is, include these. That is, a child has to be triaged as having emergency signs or priority signs. They have to receive emergency treatment. You need to take a history.
How many weeks of birth we don't give the hepatitis B? How many weeks of birth?
Sorry, Melissa.
The hepatitis B? 1 month.
Melissa,
For the Hep B. For the Hep B, but the BCG we can give. But the Hep B we give at 1 month.
Okay. I've just done it. It's okay. Sorry. I'll just keep going. The standard way in which we manage any sick child applies to a child with diarrhea. We need to, because severe dehydration is an emergency sign, we need to take a history and do an examination. Sometimes laboratory investigations are needed. For example, checking a child's acid-base status and their electrolytes is often quite important if you've got severe diarrhea. Make a diagnosis. And sometimes children with diarrhea can present, and it's not just acute gastroenteritis. There might be something else wrong, such as appendicitis. We should go through these 10 stages of management in any sick child, including children who have acute diarrhea. Because the differential diagnosis, when we think about acute vomiting and diarrhea in a child, you need to think broadly. Often it'll be just acute watery diarrhea from gastroenteritis, but also think, could this be a child, if the child's uncharacteristically unwell, then they might, or if they've got a very high fever, or they've got severe abdominal distension, or they've stopped passing urine at all, or they're very pale, or they're very toxic or unwell, they might have one of these other conditions that can present with vomiting and or diarrhea. It's very important to just consider. Usually it'll just be acute viral gastroenteritis, but it's important that we don't miss these other conditions such as sepsis, generalized sepsis or dysentery. So you need to, again, ask the right questions at history. Urinary tract infection, in young children under the age of 2, about 8% of children with a urinary tract infection will present with diarrhea, and that's because of the proximity of the urinary tract to the gastrointestinal tract. Sometimes co-infection will occur. Intussusception in children, again, under the age of 2, can present with diarrhea. It's usually bloody diarrhea, those red currant jelly stools, and abdominal distension. But we need to do a full examination to assess for other features of these other diseases if you see a child who's got acute diarrhea. If a child's just got vomiting but not diarrhea, then it's very dangerous, I think, to make a diagnosis of gastroenteritis. I see many children who just present with vomiting and without any diarrhea. And if a diagnosis of gastroenteritis is made, then often another diagnosis will have been missed. And especially think of those other things that I mentioned in the differential diagnosis, but of those, sepsis can present with just vomiting and no diarrhea, a bowel obstruction, of course, or pyloric stenosis, or vomiting can be a neurological sign. So I've seen many children who presented with increased intracranial pressure with just vomiting and a poor conscious state, and they've been considered to have gastroenteritis or vomiting and diarrhea, but actually when you take a history, there's no diarrhea. So just take a good history and do a good examination of these children with these other alternative diagnoses in mind. Usually it's possible within a very short space of time to be able to exclude these other conditions just on clinical grounds alone. But when should you expect that diarrhea is not just viral gastroenteritis? And I think that there's some clues to this. One is if children have severe abdominal pain or tenderness or distension. Usually with diarrhea, children have a scaphoid abdomen, they have a sunken abdomen, but if you see the abdomen being very distended or severely tender, then maybe they don't just have gastroenteritis. You need to think that through. If the child's got bloody diarrhea or they're severely pale or they're jaundiced or they're not passing urine, then probably it's not just viral gastroenteritis. Probably there's some bacterial infection like sepsis or dysentery going on. Or if the child's systemically unwell and toxic, out of proportion to the level of dehydration. Sometimes when children are very severely dehydrated, they can look very unwell. But if they've got a high fever, if they're toxic, if they look septic, then probably it's not just viral gastroenteritis. If the child's got malnutrition or failure to thrive and diarrhea, then probably again it's not just viral gastroenteritis. And if they're a neonate with diarrhea, then they could have viral gastroenteritis, but we should always think, could that child have sepsis as well? The clinical signs of diarrhea are illustrated in this photograph of a young boy who is about 14 months of age, who was previously quite well, who developed profuse diarrhea over 3 days. And you can see that the skin turgor is very prolonged. In fact, when you pull the skin up, it stayed up and didn't, there was no skin elasticity. I think the skin turgor being more than 2 or 3 seconds, not 1 or 1.5 seconds, is right. A dry mouth and dry mucous membranes. You can see the boy's got very sunken eyes. He had very deep acidotic breathing, and you can see the intercostal recession. Sometimes, again, it's mistaken for pneumonia, but deep acidotic breathing and intercostal recession is a feature of severe dehydration. And if you can do it, measuring a blood gas and seeing whether the child's acidotic and whether their bicarbonate level is low is quite important. Sometimes there'll be increased urea and creatinine because the child will have pre-renal kidney impairment. They'll have stopped passing urine if they're very severely dehydrated like this child. And if a child's got substantial change in weight, if they've got a recent weight recorded, then that can be a good sign of the degree of dehydration. But I hope you can appreciate that this boy is severely dehydrated because he has all of those signs. Usually when we classify diarrhea and dehydration, we're looking for a gradation of severity from the child with normal or no or mild dehydration, where there's no major clinical signs that are apparent. The child's just very thirsty, usually very, very thirsty, to a child with moderate dehydration where there's a very slow skin turgor, but not very delayed, 1.5 seconds, but not very delayed. They may have some degree of tachypnea. Their blood pressure is usually maintained. And to the child with severe dehydration, where there's more than 10% of body weight lost, where the child is lethargic or unconscious, rarely drinks at all, only if conscious enough to do so, will have skin turgor being very delayed, eyes that are sunken. Often the blood pressure will be low and the pulse volume will be low. So when you assess the circulation, the pulse volume will be low and the heart rate will be rapid. They will have deep acidotic breathing, and sometimes they'll have a sunken fontanelle if they're young infants, or if they're infants with an open fontanelle. you need to decide the route of fluid replacement. And I'm sure you know that for the vast majority of children with mild dehydration or diarrhea with no dehydration, then you just continue breastfeeding them and give some extra oral rehydration solution. If they've got moderate dehydration, again, don't starve the child. Keep them breastfeeding if they can, because almost all children with moderate dehydration can be rehydrated enterally, either with breast milk or with oral rehydration solutions. So give plenty of oral rehydration solution. If the child's not taking it well, then a nasogastric tube can be put down. It's only when you've got severe dehydration that intravenous fluid replacement becomes really something that should be considered. Mostly, if a child's got moderate dehydration and vomiting, once you start to rehydrate them, their vomiting settles down and they're able to tolerate the oral rehydration solution. The oral rehydration solutions that you should know about, the World Health Organization, ORS, has a sodium level of 90 millimoles per litre and potassium of 20, and it has a small amount of glucose. Remember I said that some fizzy drinks like Sprite or Solo or other forms of lemonade have too much sugar, much too much sugar, and they will cause an osmotic diarrhea. But ORS has a low amount of glucose and exactly the right amount of glucose, so that for every glucose molecule that is absorbed, then a sodium molecule and a water molecule is also absorbed. And that's the mechanism by which oral rehydration works on the existing small intestinal mucosal enterocytes. You can make up oral rehydration solution either with ORS, or you can make it a homemade solution is 8 level teaspoons of sugar plus half a level teaspoon of salt into a litre of water, and add some potassium, some coconut water if you can, or mashed ripe bananas. That will add the potassium. That will make up a solution that's almost the same as oral rehydration solution. If you don't have a teaspoon, then a thumb, 2-finger pinch of salt and a 3-finger scoop of sugar into a pint of clear water is the best you can do. But mostly we have ORS. This is another child with severe dehydration, and he illustrates the features I mentioned before, and that was the very sunken scaphoid abdomen. This is just severe rotavirus diarrhea, and you can see how the abdomen is very sunken, and his eyes are very sunken, and he's quite lethargic. This child also has severe dehydration. More than 10% of his body weight has been lost in the few days of his diarrhea. If a child's severely dry, then they need intravascular resuscitation, and you should put in an intravenous drip. Usually you can get a peripheral drip in, but sometimes you need to revert to either a central line or an intraosseous needle, but usually a peripheral line is okay. If you can't do that, then passing a nasogastric tube and rehydrating the child can work well. And so giving the same volume of fluid by nasogastric tube as what you're giving intravenously can work, and it can be safe. You need to watch that the child's not at risk of vomiting and aspirating, but and so having the child head elevated 30 degrees up is a useful thing to do. Usually after 20 mils per kilo of saline or Hartmann's solution intravenously, then you need to reassess the blood pressure and the pulse volume and see if the respiratory rate's gone down a bit, which would indicate that the acidosis is resolving. And then you usually rehydrate over 12 hours. Some people rehydrate over 6 hours, and some people delay it as long as 24 hours. I think over 12 hours is about right. And again, the fluids that we should use, ideally a balanced salt solution. It is a solution that's got a sodium level and a chloride level and glucose and potassium that's quite similar to extracellular fluid or plasma. Hartmann's solution is one of those, or Ringer's lactate, they're the same things. There's another solution called Plasma Light, which is an intravenous solution, which is also very good. And if you don't have that, then using half normal saline plus 2.5% dextrose plus 20 millimoles of potassium is okay, but it's not as good as using Hartmann's solution with some glucose in it. If, as I said, if you at some stage during your training, you should learn how to put in a central line. And this is a boy who had a femoral venous central line placed into the femoral vein. It can be done by, we can learn how to do it. These days, it's often done with ultrasound, looking for the femoral vein, but it can also be done just with surface markers and manual palpation. It's not that hard, and it's a worthwhile skill to learn, because sometimes in severely dehydrated children where you can't get a drip in of an adequate size, you can put in a central line. These are interosseous needles, which are these are properly used interosseous needles that can be inserted into the marrow cavity of the tibia, just below about a centimetre below the tibial tuberosity. If you don't have formal interosseous needles, then sometimes it's possible to use a lumbar puncture needle. These are interosseous needles that have been inserted into children with severe shock using a lumbar puncture needle, which will, of course, go through bone. Better to use peripheral access or nasogastric access or a central line if you can. When you're thinking about replacement of fluid, the rehydration phase, we've gone through this before, but think about the maintenance fluid that a child of that weight and age needs normally. Think about their deficit, the amount of the percentage of body water that they've lost, and think about their ongoing losses. So those three things you need to replace the fluid for: the maintenance, the deficit, and the ongoing losses. And of course, you can't estimate what the ongoing losses are going to be in the next 6 or 12 hours, but you can ask the parents how many times has the child had diarrhea in the previous 6 hours, and I always try to reproduce that. So if the child's had 4 bouts of diarrhea in the last 6 hours, then I'd be giving an extra 4 times 50 mils if the child's under 2 years, or 4 times 100 mils if the child's over 2 years. You add that into your calculation for the fluid you're going to replace in the next 12 hours. You should correct shock, but then you replace the deficit usually over 12 hours. I'll just go through this exercise. This is, again, a 14-month-old boy who for 3 days had vomiting and diarrhea. And these are clinical features. We've gone through these, but he has severe dehydration. He's at least 10% dehydrated, and his weight is 9.2 kilos. A child who's 10% dehydrated, weighing 9.2 kilos, will have 900 mils as a deficit. That's 10% of their body weight. So that's their water deficit. And if you're going to replace that over 12 hours, then that's 900 divided by 12, which is 75 mils an hour. That's quite a lot of fluid, and sometimes we underestimate the amount of fluid a child needs in the first 6 and 12 hours. This boy's maintenance is 9.2 his weight times 100 mils per kilo, so 920 mils for the day, for a 24-hour period, 100 mils per kilo per day. And remember, you're going to replace that over 24 hours, so you can divide 920 by 24 to get the volume that you should be replacing in the next hour and every hour for the next 12 hours. If you assume, as I said, that this child's you ask the parents and they say he's had 5 diarrheal stools in the last 12 hours, so in the next 12 hours, he might have another 4 diarrheal stools. And so that's 4 times 50. He's under 2 years of age. So that's an extra 200 mils over the next 12 hours. And so that's another 17 mils an hour. So you add that up, 75 plus 38 plus 17, that's 130 mils this child will need per hour for 12 hours. And for many children with diarrhea, children of this age, we would think 130 mils is a lot of fluid, but that's what they need. And if you don't replace that much fluid, then you'll come back in 6 hours and reassess the patient, or a few hours and reassess the patient, and the child may be even more dehydrated than what they were before. So think about how to calculate the deficit, the maintenance, and the ongoing losses, and replace all of that over a 12-hour period. I think it's best not to replace over 24 hours. It's too long, and it means that if you didn't get it quite right, you'll come back in the following day and the child won't be rehydrated, whereas you really want the child to be rehydrated over a fairly short period of time, in which time you reassess the patient, but you don't want to wait another day while the child's got severe dehydration. So I think it's best to replace a bit quicker. Some people have replaced over 6 hours, but sometimes that can be too quick for some children. So I think 12 hours is good for most children. When children lose water and salt, remember there's the intracellular compartment of the body, there's the extracellular compartment, there's the intravascular compartment, and of the extracellular fluid, there's the intravascular compartment and the interstitial compartment. The composition of water and electrolytes within the cells is quite different to the composition of water and electrolytes outside the cells. And when most children have acute dehydration, acute vomiting and diarrhea causing water and electrolyte loss, if they have a normal serum sodium, if their serum sodium is 140 or 135 to 145, then mostly what they've lost is extracellular water and solutes. And that's because the electrolyte composition of the small bowel is similar to that of the extracellular fluid. So what the child loses is similar to the extracellular water. But if for some reason the child's had hypernatremic dehydration, that is, their sodium level is very high. I've seen children with sodium levels of 160, 80, 180, or even close to 200 millimoles per litre, then they'll have lost more water than they will lose salt. And a lot of that fluid loss is then intracellular. That is, they've lost water from inside the cells, because if the serum sodium is very high, if it's 160, then water moves out of cells into the intravascular compartment. And so children with hypernatremic dehydration won't always manifest the same clinical features, because most of the water that they've lost is from the intracellular compartment. And these children are at very high risk of major complications, including death, sometimes because their degree of dehydration is not recognized. So in any child who's got severe dehydration, we should measure their serum sodium. It's very important. There are some circumstances under which hypernatremic dehydration is more common. If a child's had a very high fever, or they live in a very hot and dry environment where they're losing lots of insensible losses, or they have this high glucose containing fluid replacement, like if someone gives them fizzy drinks or lemonade, then they may get an osmotic diarrhea where you lose more water than you lose salt. I wanted to touch on this. I said that it's important to measure the serum sodium, and we know how important it is to measure the serum potassium in children with diarrhea, because many of them have hypokalemia, and that might make them very, very lethargic. The other thing to measure in children with severe dehydration is to see whether they've got a metabolic acidosis, and by doing that, you can measure their serum pH and their bicarbonate level. And children with severe dehydration can have acidosis from 4 different reasons. The most common one is bicarbonate losses. The small intestinal fluid contains a lot of bicarbonate, because bicarbonate is produced in the small intestine to help neutralize the acidic fluid that comes from the stomach. So the stomach's producing hydrochloric acid all the time, and that is neutralized in the small intestine by bicarbonate that's secreted by the pancreas. So if a child has a lot of small intestinal losses, then they'll be losing a lot of bicarbonate. That's the main reason for metabolic acidosis in acute gastroenteritis, for example. Sometimes children with, very commonly actually, children who've got severe vomiting and diarrhea will be ketotic as well. So they will have increased levels of ketone bodies in their blood, not from diabetic ketoacidosis, but from starvation ketosis. Sometimes if children have severe dehydration or shock, they'll have a lactic acidosis because of inadequate severe dehydration leading to inadequate oxygen delivery to tissues and therefore anaerobic metabolism at the tissues, and they'll have a lactic acidosis. And sometimes children with severe dehydration will have uremia because they've got impaired perfusion to their kidneys, so they've got an acute kidney injury, and they'll have a high urea and high phosphate levels, and that's acidic itself. So uremia is a uncommon but more end-stage form of metabolic acidosis. Mostly it's bicarbonate losses. And there was a study, the reason I'm talking about this is that there was a study done, just published this year, which from India, looking at whether or not bicarbonate replacement in severe dehydration is a good idea. And this is the study published in the Indian Journal of Paediatrics. And this study divided children with severe dehydration and a metabolic acidosis into two groups. One received just Hartmann's solution for full replacement of their deficit and their maintenance fluids, and the other group received Hartmann's solution plus an additional bicarbonate replacement in a second intravenous line. And this study showed that there was more rapid resolution of the acidosis, which is not surprising, but there was also less use of inotropes, and there was fewer children died. It was a small study, but I think it's quite a useful thing to know, and it underlines why we really should be trying to, in children with severe dehydration, we should be trying to measure their acid base and their sodium and electrolytes and get that result back as soon as possible, so you can replace their, if they've got a very severe metabolic acidosis with a bicarbonate less than 15, then ideally they could have some bicarbonate replacement as well. Regarding which children should be admitted to hospital who've got diarrhea, acute diarrhea, well, anyone with moderate or severe dehydration generally is admitted either to a short stay unit or to the ward. And there's other reasons too. It's if you're uncertain about the diagnosis, if you're worried the child might have a surgical abdomen, or they might be septic, or some other problem, or they just look too sick and too toxic, then very important to admit them, not to just call it gastroenteritis and say you can go home with some ORS. That happens quite a lot, and many children suffer from that. If they're a neonate or a very young infant, then there's a higher risk that the child will get dehydrated quickly, or they may have some other problem like sepsis or some other reason for having diarrhea. If the child's got some major comorbidity like severe malnutrition or some other comorbidity, or if the home management is very difficult, if the family are poorly educated and can't make up ORS at home, if it's a chaotic and crowded house, for example, if it's going to be very difficult for parents or a parent to provide home management, then having a child stay for a 24-hour period in an emergency department where they can get rehydrated and the family can get some education. I think that's the way most people would manage it now. And if they're very sick, obviously admit them to the ward. If a child's got severe dehydration, we've talked about this before, but try to manage the patient in a intensive care area where there's good monitoring, and use as well as monitoring at least once their metabolic, their acid base and their electrolytes, use a pediatric monitoring and response chart so that if they're not responding well, then that can be detected early and a reassessment done and some corrective measures taken. If children with severe dehydration are managed at the end of the ward and no one looks at them for another 24 hours, then you might come back in 24 hours time and find the child is just as dehydrated, or they might have developed sepsis or some other complications. So children with severe dehydration should be managed in the ICU where you can. And now I lastly want to talk about indications for antibiotics, because I've said most diarrhea is due to viral gastroenteritis and we don't need to give antibiotics. In fact, those children do worse if you give them antibiotics. But there are some situations where you suspect that diarrhea is not just due to viral gastroenteritis, it's not just watery diarrhea, or the child has some other features like we talked about, abdominal distension or pain or extreme pain or tenderness, or they look very toxic, or they've got evidence of dysentery with bloody diarrhea. Then you need to think about what the pathogen is likely to be. And remember we said that the main alternative pathogens are Shigella flexneri, causing dysentery, or Campylobacter, Campylobacter jejuni, sometimes causing dysentery, but often just causing vomiting and diarrhea. And those patients, if they're very sick, if it's severe, then ciprofloxacin will cover both. Ciprofloxacin covers Shigella flexneri well. Cotrimoxazole and amoxicillin sometimes does, but often doesn't, often don't currently. But using ciprofloxacin or erythromycin for Campylobacter, or using ciprofloxacin for Shigella is probably will cover those two other common causes of bacterial gastroenteritis or bacterial diarrhea. That's all I want to say today. We've talked, I guess, about the pathogenesis, the causes, the assessment and the treatment of children who have diarrhea. And I know this is an everyday topic, but I think it's useful to cover that and to understand the pathophysiology around different causes of diarrhea. And this is something you can use in your study. So thanks very much. And I'm just going to stop the recording. And if there's any questions, I'm happy to answer those questions.